Okay, let's unpack a truly formidable challenge in the world of medicine. Imagine microorganisms so incredibly resilient, so sort of cunning in their survival strategies that they shrug off most of our pharmaceutical arsenal. That's the complex universe of mycobacteria, and today we're embarking on a deep dive into the specialized drugs we use to fight them. Our mission with this deep dive is to arm you with a profound understanding of these complex treatments, equipping you with the kind of insights an elite professional needs, to navigate the toughest cases. We're going to master this information.
And what's truly fascinating here is how these organisms fundamentally challenge our conventional understanding of antibiotic therapy. They really force us to adopt very specific long-term and, well, often multifaceted strategies. Unlike the quick courses of antibiotics we might take for, say, a common bacterial infection. Mycobacterial infections, particularly tuberculosis, demand an entirely unique and sustained approach, and that's precisely because of their inherent tenacity and sophisticated resistance mechanisms. It's quite a testament to evolutionary adaptation.
So when we talk about tenacity, why are these tiny invaders so incredibly tough to defeat? Why can't we just hit them with a standard antibiotic and expect them to clear up quickly, like with, I don't know, strep throat? There must be some deep biological reasons at play here.
You've hit on the core of the problem, and it truly is a biological marvel in terms of its resilience. Mycobacteria possess a whole suite of intrinsic resistance mechanisms that make them uniquely formidable. First, and this is really foundational, they're simply intrinsically resistant to most common antibiotics. This isn't something they acquire over time due to exposure. It's an inherent part of their baseline biology. Think of it as being born with a built-in shield.
So they're already starting the fight with a significant advantage. Wow, that's a game changer right there.
Precisely. And on top of that, their growth rate is incredibly slow. Many of our most effective antibiotics are designed to target rapidly growing cells. They disrupt processes like cell wall synthesis or protein production during active replication. But against slow-growing organisms like mycobacteria, these drugs are, well, relatively ineffective. Their molecular targets just aren't active enough or aren't cycling frequently enough for the drug to bind and, do its work. It's almost like our fast-action drug are trying to hit a slow-motion target.
That's a great analogy. So they just sort of glide past the incoming attack. And I've heard they have another cunning trick, dormancy. Is that right?
Absolutely. And it gets even more complicated because of that. Mycobacterial cells can enter a state of dormancy, kind of like metabolic hibernation. In this non-replicating state, they were even more resistant to many drugs, often killed only very slowly, or in some cases not at all. Imagine a hostile force that can simply put itself into suspended animation, just waiting out the storm of our medications. This persister phenomenon is a huge challenge in eradication.
Wow. That's a serious survival tactic, slow and capable of hiding out. And speaking of hiding, their cell walls are legendary for being tough, aren't they?
They are. Their lipid-rich cell wall is perhaps their most iconic defense mechanism. This unique, waxy structure acts as a physical shield, making the mycobacterial cell remarkably impermeable to many antimicrobial agents that would otherwise easily penetrate other types of bacteria. It's a highly selective, almost impenetrable barrier that keeps many of our drugs from even getting inside the cell to begin with.
Okay, so they're slow, they can hibernate, and they've got this impenetrable fortress of a cell wall. What else makes them so frustratingly resilient for us to treat?
Well, many mycobacterial species, and Mycobacterium tuberculosis is the prime example here, are intracellular pathogens. This means they actually reside and replicate inside our own immune cells, specifically macrophages. It's like they're hiding within the very cells meant to destroy them, using them as a sanctuary. And this makes them inaccessible to drugs that penetrate these host cells poorly. Imagine a drug trying to find a needle in a haystack, but the haystack is inside a fortress, and the needle is inside another smaller box within that fortress. It's layers of difficulty.
So a drug needs to get past the cell wall, into the bacterial cell itself, and then into our immune cells to truly reach them. That sounds incredibly difficult.
It is. And finally, mycobacteria are notorious for their ability to develop acquired resistance to drugs. If a drug is used improperly, for instance, as a single agent, these organisms can quickly mutate and render that drug ineffective. This raises an absolutely critical question. If they're so good at developing resistance, how do we even begin to treat them effectively in a way that truly leads to a cure?
Right. And here's where it gets really interesting and, frankly, quite brilliant. Given all these formidable obstacles, what's the fundamental principle that guides their treatment? How do we even begin to outsmart such a cunning and resilient foe one that can seemingly evolve to evade our best efforts.
The fundamental principle is rooted in a probabilistic approach to drug resistance, combination therapy, and prolonged treatment. You simply cannot treat active mycobacterial infections, especially tuberculosis, with a single drug. It just won't work long term. And understanding the why behind this is crucial for mastering this field.
So why is that combination therapy so absolutely critical? What's the deep reasoning behind it?
It really comes down to basic microbiology and probability. Drug-resistant mutants are naturally present in any large population of susceptible mycobacteria. We're talking about roughly one resistant bacillus in every 10 to the power of 6 susceptible ones, maybe even 1 in a million. Now, consider that a typical tuberculous lesion in a patient can contain more than 10 to the power of 8 tubercle bacilli. That's potentially hundreds of millions of bacteria. This means you can easily have thousands, even millions of resistant mutants already present before treatment even begins. So if you use a single drug, these resistant mutants are readily selected for because they face no competition from other drugs. They rapidly multiply, leading directly to treatment failure and often a much more challenging infection to deal with later.
Okay, so if you hit them with just one drug, those rare pre-existing resistant ones suddenly have the entire field to themselves to multiply unchecked. It's like clearing out all the susceptible weeds, allowing the drug-resistant superweeds to just flourish.
Exactly. That's a perfect analogy. But here's the mathematical elegance, the beauty of the strategy. If you use 2 independently acting drugs in combination, the probability that a bacillus is initially resistant to both drugs drops dramatically. It becomes approximately 1 in 10 to the power of 6 multiplied by 1 in 10 to the power of 6, which is 1 in 10 to the power of 12. That's a truly astronomical number, way, way more than the number of infecting organisms typically found in even the largest lesions. This mathematical reality makes it absolutely essential to use at least 2, and often more, active agents to treat active tuberculosis. This strategy prevents the emergence of resistance during therapy, ensuring we don't inadvertently select for a more formidable opponent down the line.
That's a truly brilliant strategy, stacking the odds astronomically against the pathogen. And that leads to the second, equally crucial part of the principle, prolonged treatment. Why is that necessary even with combination therapy?
Yes. Because of their slow growth rate and the ability of some cells to become dormant and hide out, as we discussed, the overall response to chemotherapy is inherently slow. We simply cannot kill them off in a week or two. It's just not possible. Treatment must be administered for months, sometimes even years, depending on the specific drugs used and the patient's condition. This long duration is vital for eradicating all the different populations of bacteria within the body, including those slow-growing or dormant ones that are much harder to kill and require sustained exposure to the drugs. It's definitely a marathon, not a sprint.
Okay, now that we understand why these infections are so tricky, why they demand such a sophisticated and deeply strategic approach, let's pull back the curtain on the heavy hitters, the drugs that form the backbone of TB treatment. These are our first-line defenders, the ones we reach for first.
Right. For drug-susceptible tuberculosis, our primary reliance is on a set of first-line agents. Traditionally, this has involved a 6 to 9 month regimen consisting of isoniazid, or INH, rifampin, pyrazinamide, and ethambutol. Within this powerful quartet, isoniazid and rifampin are universally considered the most active. In fact, a 9-month combination of just isoniazid and rifampin can effectively cure 95–98% of cases caused by susceptible strains, which really speaks to their incredible potency.
But you mentioned a newer, potentially shorter regimen, right? That sounds like a significant development.
That's absolutely correct, and it represents an exciting advancement in the field. There's now a newer 4-month treatment regimen available, which includes rifapentine, moxifloxacin, isoniazid, and pyrazinamide. This newer regimen has been rigorously studied and found to be non-inferior to the traditional 6-month standard for drug-susceptible pulmonary TB. Now, this applies specifically to individuals aged 12 years and older who weigh at least 40 kilograms. And importantly, this includes HIV patients who are receiving or are planned to initiate efavirenz-based antiretroviral therapy, addressing a crucial co-infection challenge.
So for both regimens, there's typically an initial intensive phase and then a continuation phase. Could you elaborate on how those phases work and why they're structured that way?
Certainly. Both the traditional and the newer regimens begin with an initial intensive phase of treatment, which typically lasts for the first 2 months. This intensive phase is critical for several reasons, not least because of the existing prevalence of resistant strains globally. The addition of pyrazinamide during this initial phase is particularly important. Pyridinamide is uniquely active against the mycobacteria residing in the acidic environment of macrophages and necrotic lesions, acting as a powerful sterilizing agent. Its inclusion allows the total duration of therapy to be significantly reduced from what it would be otherwise, making treatment more feasible and shorter for patients.
And when do clinicians decide which specific drugs to use? Is it always a four-drug start?
In practice, yes, therapy is almost always initiated with a four-drug regimen, whether it's the traditional combination of isoniazid, rifampin, pyrazinamide, and ethambutol, or the newer rifapentine, moxifloxacin, isoniazid, and pyrazinamide. This empirical approach is maintained until the susceptibility of the patient's specific clinical isolate to these drugs has been determined by laboratory testing. This initial broad coverage is vital to ensure that any potentially resistant strains present are addressed right from day one. Once we know the isolate is susceptible to at least isoniazid and rifampin, we can then transition to the continuation phase, maybe dropping a drug.
What does that continuation phase look like then once susceptibility is confirmed? And what's ethambutol's specific role, or perhaps its lack thereof, in the grand scheme?
Right. For susceptible isolates, the continuation phase for the traditional regimen involves an additional 4 months of isoniazid and rifampin, just those two. For the newer regimen, it's an additional 2 months of rifapentine, moxifloxacin, and isoniazid. Now, about ethambutol. It or other drugs don't really substantially shorten the overall treatment duration beyond what INH and rifampin already achieve. The fourth drug, like ethambutol in the traditional regimen, is primarily included in the initial phase as a safeguard, a bit of insurance. It's there in case the isolate proves to be resistant to either isoniazid, rifampin, or maybe even both. If susceptibility to INH and rifampin is confirmed early, meaning the bacteria are fully susceptible to those two core drugs, ethambutol isn't strictly necessary for the remainder of the treatment. Its role is protective, kind of like a safety net, as you said.
That makes perfect sense. It's there for the uncertainty. And speaking of resistance, what are the current trends we're seeing, especially multi-drug resistance? That's a term that gets a lot of attention.
It does, and for very good reason. In the USA, the prevalence of isoniazid resistance among clinical isolates is approximately 10%. So roughly 1 in 10 cases might have some resistance to this key drug right off the bat. More concerning is multi-drug resistance, MDR-TB, which is strictly defined as resistance to both isoniazid and rifampin. In the USA, this was reported at 1.9% in 2017 and has remained remarkably stable for about 20 years, which is somewhat reassuring. However, it's crucial to understand the global picture. Multi-drug resistance is much more prevalent in many other parts of the world, particularly in Eastern Europe and parts of Asia. It poses a significant and ongoing global health challenge. Resistance to rifampin alone, without accompanying INH resistance, is actually quite uncommon, which is fortunate given rifampin's central role in treatment.
Okay, let's kick off our deep dive into individual drugs with isoniazid, or INH, a true workhorse in TB treatment. What makes it so foundational?
Well, isoniazid really stands out as arguably the most active drug for tuberculosis caused by susceptible strains. It's a small molecule, freely soluble in water, which allows it to distribute effectively throughout the body. Its structural similarity to pyridoxine, which we'll delve into later when we discuss adverse effects, is quite notable. In vitro, it's incredibly potent, inhibiting most tubercle bacilli at concentrations of 0.2 micrograms per milliliter or even less. Just a tiny amount is needed. It's also bactericidal for actively growing tubercle bacilli, meaning it directly kills them. However, it's generally less effective against most nontuberculous mycobacteria. Crucially, isoniazid penetrates deeply into macrophages, those immune cells where M. tuberculosis likes to hide, making it active against both extracellular and intracellular organisms. This ability to get inside the hiding places is absolutely key to its efficacy.
So it can actually seek out the bacteria even when they're concealed within our own cells. Wow, that's a huge advantage. How exactly does it work its magic at the molecular level, and then how do mycobacteria fight back against it?
Isoniazid's mechanism is quite sophisticated. It's a classic example of a prodrug. It's actually inactive until it's metabolized by the mycobacterium itself. Specifically, it's activated by an enzyme unique to the mycobacterium called KATG, which is a catalase peroxidase enzyme. Once activated by KATG, this form of isoniazid becomes reactive and forms a covalent complex with an acyl carrier protein, ACPM, and a beta-ketoacyl carrier protein synthetase, KATZUNG. The ultimate result of this chemical tango is that it blocks the synthesis of mycolic acids. These are truly unique long-chain fatty acids that are absolutely essential components of the mycobacterial cell walls. They're what give the cell wall its waxy, impenetrable quality. Without these, the cell wall cannot be properly formed, the bacterium loses its integrity, and it's severely compromised.
That's a clever biochemical attack, so it sabotages their own unique building blocks. And how does resistance to this crucial sabotage emerge?
Resistance to isoniazid can arise from several distinct mutations, a testament to the mycobacterium's adaptability. One common mechanism involves mutations that result in the overexpression of the NHA gene. This gene encodes an enzyme involved in mycolic acid synthesis, and its overexpression essentially provides more target for the drug to bind to. But by overwhelming the system, it reduces the drug's effectiveness. These NHA overproducers typically express low-level isoniazid resistance. And importantly for clinical management, they also show cross-resistance to ethionamide, which is another anti-TB drug.
So if they're resistant to INH in this way, they're likely resistant to ethionamide too. That's important for treatment planning. What are other resistance mechanisms?
Yes, exactly. That's a key point. Another significant mechanism is mutation or deletion of the KG gene itself. If the mycobacterium can't produce or properly use KG, it simply can't activate the isoniazid prodrug. No activation, no effect. These KG mutants express high-level isoniazid resistance, and interestingly, they often do not show cross-resistance to ethionamide. This helps distinguish them from NSEA mutants in the lab, which is useful for guiding second-line therapy. Furthermore, promoter mutations leading to overexpression of APC, a gene involved in protecting the cell from oxidative stress, and mutations in Cas can also contribute to resistance. The organism finds multiple sophisticated ways to evade this critical drug, underscoring the constant evolutionary pressure it faces.
Okay, so once it's absorbed and working to block those mycolic acids, how does isoniazid actually move through and distribute itself within the body?
Isoniazid is readily absorbed from the gastrointestinal tract, and for optimal absorption, it really should be taken on an empty stomach. Taking it with a fatty meal can actually decrease its peak concentrations by up to 50%, which could be clinically significant in some cases. A typical 300 milligram oral dose in an adult, or 5 milligrams per kilogram in children, achieves peak plasma concentrations of 3,000 micrograms per milliliter within 1 to 2 hours. A key advantage of isoniazid is its excellent distribution. It diffuses widely and readily into all body fluids and tissues. This includes superb penetration into the central nervous system and cerebrospinal fluid, where concentrations can range between 20% and 100% of simultaneous serum concentrations. This broad distribution is absolutely essential for treating systemic infections, especially those involving the brain or other difficult-to-reach sites.
That's fantastic penetration. And how is it processed and eliminated from the body? Are there individual differences in how quickly people metabolize it? I think I've heard about this.
Yes, this is a fascinating aspect of its pharmacokinetics and a classic example of pharmacogenetics. Its metabolism, particularly acetylation by the liver enzyme N-acetyltransferase, is genetically determined. Individuals are categorized as either rapid acetylators or slow acetylators. Rapid acetylators clear isoniazid much more quickly, resulting in average plasma concentrations about 1/3 to 1/2 of what's seen in slow acetylators. Their half-lives are less than 1 hour, compared to about 3 hours in slow acetylators. Now, for daily dosing, this more rapid clearance in fast acetylators is usually of no significant therapeutic consequence, meaning the drug still works effectively. However, knowing this difference is vital because subtherapeutic concentrations can become a concern if the drug is administered less frequently, like once weekly, or if the patient experiences malabsorption issues. It's a good example of how your genetics can influence drug efficacy and potentially toxicity.
What about its excretion, especially for patients with kidney or liver issues? Does that influence dosing?
Isoniazid metabolites, along with a small amount of unchanged drug, are primarily excreted in the urine. This is generally good news because the dosage typically does not need to be adjusted in cases of renal failure. The kidneys handle it okay. However, for patients with severe pre-existing hepatic insufficiency, dosage adjustment is not as clearly defined. The liver is involved in metabolism after all. In such cases, if a reduction in dose is being considered, it should ideally be guided by monitoring serum concentrations, as the liver does play a role in its metabolism and accumulation could occur.
You mentioned earlier its pro-drug nature and effects on the liver. Does isoniazid have any significant drug interactions that clinicians really need to be aware of? This is where an elite professional needs to be sharp.
It absolutely does, and this is where the complexity of polypharmacy with TB drugs truly emerges. You really need to know this stuff. Isoniazid inhibits several cytochrome P450 enzymes, which are crucial for metabolizing many other drugs in the liver. This inhibition can lead to increased concentrations of medications such as phenytoin, carbamazepine, and certain benzodiazepines, potentially raising their toxicity to dangerous levels. However, here's where it gets really interesting and something a true professional needs to understand deeply. When isoniazid is used in combination with rifampin, which, as we'll discuss in a moment, is a potent CYP enzyme inducer, the concentrations of these other medications are often paradoxically decreased. Rifampin's strong inducing effect can override isoniazid's inhibiting effect, creating a complex and sometimes unpredictable interplay. This intricate balance highlights the meticulous attention required when managing these regimens, especially in patients on multiple medications for other conditions.
Wow, that's complex. So, given all this, how is isoniazid typically used in the clinic for active TB, and what about for latent TB?
For active tuberculosis, the typical dosage of isoniazid is 5 milligrams per kilogram per day, with a standard adult dose being 300 milligrams given once daily. In more serious infections, or if there are concerns about malabsorption, the dose can be increased up to 10 milligrams per kilogram per day. For intermittent dosing regimens, like twice or 3 times weekly in combination with another antituberculous agent like a rifampin, a higher dose of 15 milligrams per kilogram or 900 milligrams is often used. It's typically given orally, but it can also be administered parenterally at the same dosage if the patient can't take oral medications for some reason.
And for preventing active disease once someone is exposed, for latent PB infection.
Isoniazid is also a cornerstone as a single agent for the treatment of latent tuberculosis infection, or LTBI. In this context, the dosage is 300 milligrams per day, or 900 milligrams twice weekly, and the duration is typically 9 months. It's a long course. Now, for patients with conditions predisposing them to neuropathy, which is a known adverse effect of isoniazid, it's strongly recommended to concurrently administer pyridoxine, or vitamin B6. Usually 25-50 milligrams per day is sufficient to prevent that specific toxicity. This is a critical preventive measure that every clinician needs to remember.
That brings us nicely to adverse reactions. What are the major warning signs and side effects patients and clinicians need to watch out for with isoniazid?
Right, the incidence and severity of untoward reactions to isoniazid are definitely related to both the dosage and the duration of administration. We generally see 2 main categories of reactions. First, immunologic reactions. Occasional fever and skin rashes, which are fairly common drug reactions, More rarely, drug-induced systemic lupus erythematosus has also been reported, which is more serious.
And the more serious, direct toxicities, the ones we really worry about.
This is where we see the most significant concerns, particularly for patient safety. Isoniazid-induced hepatitis is the most common major toxic effect. It's absolutely crucial to distinguish this from the minor, asymptomatic increases in liver aminotransferases, liver enzymes, which are seen in 10–20% of patients and usually don't require the drug to be stopped. They often resolve on their own. Clinical hepatitis, however, is a much more serious event, occurring in about 1% of isoniazid recipients. Patients might experience symptoms like loss of appetite, nausea, vomiting, jaundice, and right upper quadrant pain. This can be fatal, particularly if the drug is not discontinued promptly and it's associated with clear histologic evidence of hepatocellular damage and necrosis. Recognizing these symptoms and acting quickly is paramount.
That sounds like a very serious risk. Is the risk of hepatitis the same for everyone, or are there specific patient groups that are more vulnerable?
No, the risk is highly dependent on age. It's actually rare in individuals under 20, but the risk progressively increases with age. About 0.3% in those aged 21–35, 1.2% in those 36–50, and jumps significantly to 2.3% in those 50 and above. The risk is also greater in individuals with alcohol use disorders and possibly during pregnancy and the postpartum period. And if isoniazid hepatitis develops, it absolutely contraindicates any further use of the drug.
Yeah.
There's no going back. Once that severe reaction occurs, you have to stop it and never use it again in that patient.
That's a very serious concern, especially with our hypothetical patient's alcohol use in the case study we'll discuss later. What about other direct toxicities beyond the liver?
Peripheral neuropathy is another important adverse effect. It's observed in 10–20% of patients receiving dosages above 5 milligrams per kilogram per day, though it's less frequent with a standard 300 milligram adult dose. This neuropathy is more likely in slow as chelators remember them, and in patients with predisposing conditions such as malnutrition, alcohol use disorder, diabetes, AIDS, and end-stage renal disease. The mechanism here is interesting. The neuropathy is caused by a relative pyridoxine, or vitamin B6 deficiency, as isoniazid promotes its excretion. Fortunately, this toxicity is readily reversed by the administration of pyridoxine, even in dosages as low as 10 milligrams per day. This is a simple yet critical preventive measure.
And any effects on the brain or central nervous system?
Central nervous system toxicity is less common, but can include things like memory loss, psychosis, ataxia, which is loss of coordination, and seizures. These effects may also respond to pyridoxine supplementation. Lastly, miscellaneous reactions can include various hematologic abnormalities, the provocation of pyridoxine deficiency anemia, tinnitus, ringing in the ears, and general gastrointestinal discomfort. So, while isoniazid is an incredibly effective and foundational drug, its broad spectrum of potential side effects, especially liver and nerve issues, requires very careful monitoring and patient education for optimal and safe use.
Okay, let's shift our focus now to rifampin. This is another cornerstone of TB treatment, but one with some truly fascinating properties, especially concerning its incredibly potent interactions with other drugs. It's a drug every professional needs to understand deeply.
Absolutely. Rifampin is a semisynthetic derivative originating from Amycobacterial rifamycinica, an organism formerly known as Streptomyces mediterranei. It's a broad-spectrum antibiotic, active in vitro against a range of organisms, including gram-positive bacteria, some gram-negative organisms like Neisseria and Haemophilus species, as well as mycobacteria and chlamydia. Susceptible organisms are inhibited by concentrations of less than 1 microgram per milliliter, so it's very potent.
And its Achilles heel, if used alone, same issue as INH.
Exactly the same issue. Like isoniazid, rifampin faces the challenge of inherent resistance. Resistant mutants are naturally present in all microbial populations at an approximate rate of 1 in 10 to the power of 6 organisms. If rifampin is used as a single drug, especially in a patient with an active infection, these resistant mutants are rapidly selected for and can quickly dominate the population, leading to treatment failure. This just reinforces why combination therapy is non-negotiable for active TB. What's interesting clinically is that there's no cross-resistance between rifampin and other classes of antimicrobial drugs, which is a clinical advantage. However, there is complete cross-resistance to other rifamycin derivatives, such as rifabutin and rifapentine, meaning if an organism is resistant to rifampin, it will almost certainly be resistant to those as well because they share the same molecular target and mechanism.
So how does rifampin actually work to kill mycobacteria? What's its specific target, and how does resistance to it emerge at that molecular level?
Rifampin's mechanism of action is quite specific and elegant. It binds directly to the beta subunit of bacterial DNA-dependent RNA polymerase. That's a crucial enzyme responsible for transcribing DNA into RNA. By binding to the subunit, rifampin effectively inhibits bacterial RNA synthesis, which is a crucial step for bacterial protein production and ultimately survival. Importantly, human RNA polymerase does not bind rifampin and is therefore not inhibited by it, which accounts for its selective toxicity against bacteria. Rifampin is bactericidal for mycobacteria, directly killing them. It's particularly effective because it readily penetrates most tissues, including into phagocytic cells, those very cells where mycobacteria like to hide. This allows it to kill organisms that are poorly accessible to many other drugs, such as intracellular organisms and those sequestered in abscesses and lung cavities.
That's a powerful and selective action. And how do bacteria become resistant to this specific attack?
Resistance to rifampin typically results from one or more specific point mutations in the RPB gene. That's the gene which codes for that beta subunit of RNA polymerase we just mentioned. These tiny mutations alter the RNA polymerase structure just enough, leading to reduced binding of rifampin to the enzyme, thereby nullifying its inhibitory effect. Understanding this RPB mutation is key, as it's often the genetic marker used for rifampin resistance in diagnostic tests.
Okay. Once it's ingested, how does rifampin move through and leave the body? Is its elimination unique?
Rifampin is well absorbed after oral administration. It's primarily excreted through the liver into the bile. It then undergoes enterohepatic recirculation, a process where it's reabsorbed from the intestine back into the bloodstream before the bulk is excreted as a deacylated metabolite in the feces. Only a small amount is excreted in the urine. This predominant biliary excretion means that dosage adjustment is generally not necessary for patients with either renal or hepatic insufficiency, which simplifies its management in these often complex patient populations. Usual doses typically result in serum levels of 5-7 micrograms per milliliter. Rifampin is widely distributed throughout body fluids and tissues. However, it's relatively highly protein-bound, and achieving adequate cerebrospinal fluid concentrations usually requires the presence of meningeal inflammation, a crucial point for treating meningitis.
Now, this is where rifampin truly stands out and often complicates treatment, isn't it? It's incredibly broad and potent drug interactions. This is a point where an elite professional needs to be extremely vigilant.
You are absolutely right. If we connect this to the bigger picture, this is a major consideration in clinical practice and a frequent source of management challenges. Huge. Rifampin is a strong inducer of most cytochrome P450 isoforms, including CYP1A2, 2C9, 2C19, 2D6, and crucially 3A4. These enzymes are the primary metabolic machinery in the liver responsible for breaking down a vast array of other drugs. What this means in practice is that co-administration of rifampin significantly lowers the serum levels of numerous other medications. We're talking about drugs like methadone, anticoagulants like warfarin, immunosuppressants like cyclosporine, certain anticonvulsants. Critical HIV medications like protease inhibitors and some non-nucleoside reverse transcriptase inhibitors and integrase transfer inhibitors, oral contraceptives, and a whole host of others. This potent induction can render co-administered drugs ineffective or subtherapeutic, leading to treatment failures for those other conditions. It makes careful monitoring, dose adjustments, or outright drug substitutions absolutely essential when rifampin is part of a patient's regimen. It's a major headache sometimes.
So how is rifampin typically used in the clinic, considering all these powerful interactions and its necessity in combination therapy?
In mycobacterial infections, rifampin is typically given at 600 milligrams per day, or about 10 milligrams per kilogram per day, orally. For active tuberculosis, it absolutely must be administered with isoniazid or other anti-tuberculous drugs to prevent the rapid emergence of drug-resistant mycobacteria. We really can't overstate this. In some treatment courses, it can be given intermittently, such as 600 milligrams twice weekly. Rifampin, also at 600 milligrams daily or twice weekly for 6 months, is effective when combined with other agents for certain atypical mycobacterial infections, and, as we'll discuss later, it's a critical component in the treatment of leprosy. Interestingly, for latent tuberculosis, rifampin can be used as a single drug at 600 milligrams daily for 4 months. It's considered an effective and often preferred treatment in that context because there isn't the same burden of active, rapidly replicating bacteria to select for resistance.
Are there other non-TB uses for rifampin? It sounds like it's quite a versatile drug beyond mycobacteria.
Yes, rifampin has several important uses in other bacterial infections. An oral dosage of 600 milligrams twice daily for 2 days can effectively eliminate meningococcal carriage, making it a key prophylactic agent in outbreaks or for close contacts. It's also used as prophylaxis in contacts of children with Haemophilus influenza type B disease, typically at 20 milligrams per kilogram, up to a maximum of 600 milligrams, once daily for 4 days. Additionally, rifampin is a crucial drug in combination therapy for serious staphylococcal infections, like osteomyelitis, prosthetic joint infections, and prosthetic valve endocarditis, where its ability to penetrate biofilms and intracellular spaces is particularly valuable.
And what about the side effects patients might experience with rifampin? Anything particularly common or notable that we should warn people about?
One of the most striking, though generally harmless, side effects is that rifampin imparts an orange color to urine, sweat, and tears. Patients should absolutely be warned that it can even permanently stain soft contact lenses, which can be quite alarming if not anticipated. More significant adverse effects include rashes, thrombocytopenia, which is a low platelet count, and nephritis, kidney inflammation. It can also cause cholestatic jaundice and occasionally hepatitis, so liver function needs monitoring. Light chain proteinuria is also a common occurrence. Now, if rifampin is administered less often than twice weekly, it can cause an acute influenza-like syndrome characterized by fever, chills, and muscle aches, sometimes accompanied by anemia and thrombocytopenia. This is a key point about intermittent dosing. Its use has also been associated with acute tubular necrosis, a serious kidney condition. So while incredibly powerful, its broad effects on the body, particularly its interactions and potential for that flu-like syndrome with intermittent dosing, require careful patient education and monitoring.
Building on rifampin, we have rifapentine, an analog that offers some unique advantages, especially in those newer, shorter treatment approaches. How does it compare to its well-known cousin?
Rifapentine is indeed a close analog of rifampin, and it shares activity against both M. tuberculosis and Mycobacterium complex, or MAC. Like all rifamycins, its mechanism of action involves inhibiting bacterial RNA polymerase, the exact same target as rifampin. As you might expect, cross-resistance between rifampin and rifapentine is complete. If a strain is resistant to one, it will be resistant to the other. No surprise there. Similarly, like rifampin, rifapentine is a potent inducer of cytochrome P450 enzymes, which means it has a similar drug interaction profile. However, and this is a key advantage, when rifapentine is administered intermittently, the induction of metabolism of other medications tends to be less pronounced compared with rifampin. This can be a significant benefit in managing polypharmacy, especially in complex patients taking multiple drugs. Its toxicity profile is generally similar to that of rifampin.
So less drug interaction headache with intermittent dosing, that's a definite plus. What's unique about its half-life that allows for those less frequent doses?
Risapentine, along with its microbiologically active metabolite, 25-disacetyl rifapentine, boasts a considerably longer elimination half-life of about 13 hours, much longer than rifampin. This extended half-life means the drug stays in the body longer at effective concentrations, which is what allows for less frequent dosing in certain regimens. This can profoundly improve patient adherence to what are already very long and demanding treatment courses. Easier dosing schedules often mean better outcomes.
And how is it being used clinically now, especially in new regimens for drug-susceptible TB? This seems like a major shift.
Rifapentine is a key component of the newer 4-month treatment regimen for drug-susceptible pulmonary tuberculosis. It's administered at a dose of 1,200 milligrams once daily in combination with isoniazid, pyrazinamide, and moxifloxacin. This regimen was evaluated in a landmark study that found it to be non-inferior to the standard 6-month treatment. This is incredibly significant because it allows for a shorter overall treatment duration for specific patient groups, those aged 12 years and older who weigh at least 40 kilograms. And importantly, it includes those with HIV who are receiving or planning to initiate efavirenz-based antiretroviral therapy. This study was published after the most recent 2016 CDC treatment guidelines, but it's now incorporated into interim guidance published in 2022, signaling a real shift in clinical practice towards more streamlined, patient-friendly regimens.
So it's about making treatment more tolerable while maintaining efficacy. That's key. What about intermittent dosing for rifapentine in other scenarios? Is that still widely recommended?
Well, while intermittently dosed rifapentine, say 600 milligrams once or twice weekly, has been explored for treatment of rifampin-susceptible tuberculosis during the continuation phase, that is, after the first 2 months of therapy, and ideally after sputum cultures have converted to negative. Current treatment guidelines actually recommend against its widespread use in this intermittent fashion. This is because this regimen has shown decreased efficacy compared to the standard rifampin-based regimen in some studies. In particular, its use should be avoided in patients at higher risk of treatment failure. This includes those with positive cultures at the end of the intensive treatment phase, those with evidence of cavitation holes on chest radiographs, or patients with HIV infection. Due to an unacceptably high relapse rate, sometimes of rifampin-resistant organisms emerging. This is a critical nuance for any professional to grasp. Shorter duration or less frequent dosing isn't always better if it compromises efficacy, especially in high-risk patients.
How about for latent TB, where adherence is also a big factor? Is it useful there?
Yes, for latent tuberculosis infection, rifapentine in combination with isoniazid, typically both dosed at 900 milligrams once weekly for 3 months, totaling just 12 doses each, is an effective short-course treatment. This is a highly preferred option due to its much shorter duration compared to 9 months of INH alone, significantly improving patient completion rates. Adherence is much better. Furthermore, rifapentine combined with isoniazid, both dosed daily for 1 month, has also shown efficacy against latent TB in patients with HIV, offering another potent short-term option for that population.
And despite the potentially less pronounced induction with intermittent administration, those drug interactions are still a concern for rifapentine, right? You can't ignore them.
Absolutely not. Despite the potentially less pronounced induction with intermittent administration, special caution must still be taken to avoid drug-drug interactions. Co-administration of rifapentine can still lead to subtherapeutic levels of numerous antiretroviral agents, which is a major concern in HIV-positive patients. This underscores the need for careful medication reconciliation and monitoring. Similar to what we discussed for rifampin, it's still a potent inducer.
Now let's explore ethambutol. This drug plays a crucial supportive role, particularly in the initial phases of treatment, acting as a valuable backup, but it comes with a very specific and critical watch-out.
Right. Ethambutol is a synthetic, water-soluble, and heat-stable compound. Specifically, it's the dextroisomer, dispensed as the dihydrochloride salt. It's a key part of our initial strategy, often serving as that safety net drug we discussed earlier, especially when we don't know the resistance profile yet.
So how does ethambutol actually work at a molecular level, and what makes mycobacteria resistant to its action?
Ethambutol works by specifically inhibiting mycobacterial arabinosyl transferases. These enzymes, which are encoded by the MCAB operon, are critical for the polymerization reaction of arabinoglycan. Arabinoglycan itself is an essential component of the mycobacterial cell wall. It's a complex sugar chain that provides structural integrity. So by blocking these enzymes, ethambutol effectively disrupts the assembly of the cell wall, which is vital for the mycobacterium's structural integrity and survival. It's like stopping a specific bricklayer on their assembly line. Resistance to ethambutol typically arises from mutations that result in the overexpression of M-butene products, or from mutations specifically within the MB structural gene. These mutations alter the target enzyme, reducing the drug's binding. Susceptible strains of M. tuberculosis and other mycobacteria are inhibited in vitro by ethambutol at concentrations of 1 to 5 micrograms per milliliter.
And its pharmacokinetics, how is it absorbed, distributed, and cleared from the body? Does it get into the brain well?
Ethambutol is well absorbed from the gut. After ingesting a 25 milligram per kilogram dose, blood levels typically peak at 2 to 5 micrograms per milliliter within 2 to 4 hours. Roughly 20% of the drug is excreted in the feces, and about 50% is excreted unchanged in the urine. The significant renal clearance means that ethambutol can accumulate in patients with renal failure. Therefore, if a patient's creatinine clearance is less than 30 milliliters per minute, the dose should be reduced from daily administration to 3 times weekly to prevent toxicity. That's critical. As for distribution, ethambutol crosses the blood-brain barrier only when the meninges are inflamed, and even then, concentrations in the cerebrospinal fluid can be highly variable, ranging from maybe 4% to as high as 64% of serum levels. So its use in tuberculous meningitis can be less predictable than some other drugs.
How is it used in active TB treatment? And I'm guessing it's never used alone, similar to the other first-line drugs, right?
That's absolutely correct. As with virtually all antituberculous drugs, resistance to ethambutol emerges rapidly when the drug is used as a single agent. Never use it alone for active disease. Therefore, ethambutol is always given in combination with other antituberculous drugs. It's typically included at a dosage of 15-25 milligrams per kilogram as a single daily dose, as part of the 4-drug initial intensive phase of active tuberculosis treatment, alongside isoniazid, rifampin, and pyrazinamide. The higher dose, 25 milligrams per kilograms, may be used specifically for the treatment of tuberculous meningitis, where CNS penetration is critical. Higher doses have also been used with intermittent dosing regimens for directly observed therapy, for example, 25-30 milligrams 3 times weekly, or 50 milligrams administered twice weekly. Ethambutol also finds use in combination with other agents for treating nontuberculous mycobacterial infections, such as Mycobacterium avium complex, or M. kansasi, typically at a dose of 15 milligrams per kilograms once daily.
Okay, what's that specific and critical watch-out you mentioned earlier for ethambutol? This sounds like something every professional needs to be highly aware of.
Yes, this is the big one for ethambutol. The most common and serious adverse event associated with it is retrobulbar neuritis. This will lead to a loss of visual acuity and, crucially, red-green color blindness. It affects the optic nerve. This adverse effect is directly dose-related and is more likely to occur at higher dosages, specifically 25 milligrams per kilogram per day if continued for several months. At the standard 15 milligrams per kilogram per day or less, visual disturbances occur in approximately 2% of patients, and typically after at least 1 month of treatment. The impact on vision can unfortunately be permanent if not caught early and the drug stopped.
So it really impacts vision, and it's dose and duration dependent. That's scary. How do clinicians manage the serious risk to prevent irreversible damage?
Given this significant risk, experts strongly recommend baseline and monthly visual acuity and color discrimination testing for patients on ethambutol. Regular eye checks are essential. This is particularly important for patients on higher doses or those with impaired renal function, as drug accumulation can increase toxicity risk. Furthermore, ethambutol is considered relatively contraindicated in children who are too young to permit a reliable assessment of their visual acuity and red-green color discrimination, as they might not be able to report the subtle changes in vision or color perception that signal the start of the problem. This limitation highlights the need for careful patient selection and rigorous, ongoing monitoring to ensure patient safety while achieving effective treatment. It's a classic example of balancing efficacy with a significant specific toxicity.
Next up is pyrazinamide, or PZA. This drug is absolutely crucial for shortening treatment duration, thanks to its truly unique and targeted activity. What makes it so special?
Pyrazinamide is a synthetic relative of nicotinamide, and its use is specifically and almost exclusively limited to the treatment of tuberculosis. It's stable and only slightly soluble in water. What's truly unique about PZA and critical to its efficacy is its pH-dependent activity. It's largely inactive at a neutral pH, which is typical of extracellular environments in the body. However, it becomes highly active at an acidic pH of 5.5, where it inhibits tubercle bacilli at concentrations of approximately 20 micrograms per milliliter. This characteristic is key to its efficacy because the drug is taken up by macrophages, where it exerts its activity against mycobacteria residing within the highly acidic environment of lysosomes inside those cells. It's a remarkably targeted approach, attacking the bacteria right in their preferred acidic hiding spot.
So it's a specialist, only activated in the perfect acidic hiding spots of the mycobacteria. That's incredibly clever. How does this activation translate into its mechanism of action?
Exactly. Its mechanism of action is quite distinct and relies on the mycobacterium itself activating it. Pyrazinamide itself is a prodrug converted to pyrazinoic acid, which is the actual active form of the drug, by a mycobacterial enzyme called pyrazinamidase, encoded by the PNCA gene. This pyrazinoic acid then goes on to disrupt mycobacterial cell membrane metabolism and transport functions, leading to the bacterium's demise. Resistance to pyrazinamide can arise either due to impaired uptake of the drug into the bacterial cell or, more commonly, through mutations in the PNCA gene that impair the crucial conversion of pyrazinamide to its active form. Understanding this PNCA mutation is vital for diagnosing PZA resistance in the lab.
How does pyrazinamide move through the body once absorbed?
Pyrazinamide is very well absorbed from the gastrointestinal tract. After an oral dose of 25 milligrams per kilogram per day, serum concentrations of 30-50 micrograms per milliliter are typically achieved within 1 to 2 hours. It's widely distributed throughout the body tissues, and importantly, it penetrates well into inflamed meninges, making it highly effective for tuberculous meningitis, given its need for an acidic environment. Its half-life is relatively short, around 8-11 hours. While the parent compound is metabolized by the liver, its metabolites are primarily cleared by the kidneys. This means that for patients undergoing hemodialysis or those with a creatinine clearance less than 30 milliliters per minute, the dose needs to be adjusted. Instead of daily administration, it should be given at 25-35 milligrams per kilogram 3 times weekly. For patients with normal renal function, higher doses of 30-50 milligrams per kilogram are used for thrice-weekly or twice-weekly treatment regimens.
So it's critical to watch kidney function with PZA. How does pyrazinamide contribute to those shorter 6-month treatment courses we talked about earlier? This is its unique power, right?
Absolutely. Pyrazinamide is considered an important frontline drug used in conjunction with isoniazid and rifampin in those crucial short-course regimens of 6 months or fewer. It's particularly valued as a sterilizing agent. This means it's highly effective against the residual intracellular organisms that might otherwise persist and cause a relapse of the disease later on. These are often the persister cells hiding out in acidic environments where other drugs might struggle. While tubercle bacilli can develop resistance to pyrazinamide fairly readily, a key clinical advantage is that there's no cross-resistance with isoniazid or other antimycobacterial drugs, meaning resistance to PZA doesn't inherently imply resistance to other first-line agents. This allows for more flexibility in treatment if resistance emerges to PZA alone.
And what are the common side effects for pyrazinamide? Anything particularly notable?
The major adverse effects of pyrazinamide include hepatotoxicity, which occurs in 1 to 5% of patients, so liver monitoring is needed. Similar to INH, other common reactions are nausea, vomiting, drug fever, and photosensitivity, making skin more sensitive to sunlight. And universally, hyperuricemia. This increase in uric acid levels happens in virtually all patients taking pyrazinamide. But it's important to note that it's generally not a reason to halt therapy if the patients remain asymptomatic. Clinicians should be aware of it, monitor for gout symptoms, but it typically doesn't cause attacks unless the patient is already prone.
Okay, we've covered the core 4, the essential first-line defenders, but let's talk about a class of drugs, the fluoroquinolones, that are becoming increasingly important, particularly in new treatment strategies and for more challenging cases.
Yes. The fluoroquinolones, including ciprofloxacin, levofloxacin, gadafloxacin, and moxifloxacin, are indeed a versatile and expanding class in TB treatment. In addition to their broad activity against many gram-positive and gram-negative bacteria, they also effectively inhibit strains of M. tuberculosis at concentrations of less than 2 micrograms per milliliter. They are also active against many atypical mycobacteria. Among these, moxifloxacin is generally considered the most active against M. tuberculosis in vitro, which is precisely why it features in that newer 4-month regimen. Levofloxacin tends to be slightly more active than ciprofloxacin against M. tuberculosis, whereas ciprofloxacin shows slightly greater activity against atypical mycobacteria. While clinical data are limited for delafloxacin, its in vitro activity against mycobacteria appears to be even greater than that of levofloxacin, hinting at future potential uses.
So their role is definitely evolving. How have they traditionally been used, and where do they fit into the newer frontline regimens?
Fluoroquinolones have traditionally been reserved for treating tuberculosis strains that are resistant to first-line agents, like INH or rifampin, or for patients who are intolerant to those first-line drugs due to adverse effects. This was their primary niche for a long time. However, as you alluded to, Moxifloxacin's role is expanding significantly. It may be used more frequently as initial therapy based on recent data showing the non-inferiority of that 4-month treatment regimen we discussed earlier, the one combining moxifloxacin, rifampin, isoniazid, and pyrazinamide, when compared to the standard 6-month therapy for drug-susceptible pulmonary tuberculosis. This indicates a growing confidence in their primary role and a definite shift in treatment paradigms towards shorter courses.
What about resistance to fluoroquinolones? Given how important they are becoming, it's vital to understand this potential problem.
Yes, resistance to fluoroquinolones can develop rapidly if the drug is used as a single agent, just like the others. This typically occurs through one or more single-point mutations in the gyrase, a subunit, which is the drug's bacterial target, DNA gyrase, a crucial enzyme for DNA replication. For this reason, fluoroquinolones must always be used in combination with at least 2 or more additional active agents for treating active TB. Generally, resistance to one fluoroquinolone often indicates class resistance, meaning resistance to other drugs within the same class. However, moxifloxacin may retain some activity in strains that have developed resistance to afloxacin, offering a potential alternative in some specific cases, highlighting the nuanced differences even within a class. But generally, if resistance emerges, the whole class might be compromised.
What are the typical dosages for these fluoroquinolones when used for TB?
The typical dosage for levofloxacin is 500-750 milligrams once a day, with some clinicians increasing it to 1,000 milligrams daily if tolerated for more severe infections. Moxifloxacin is typically dosed at 400 milligrams once a day. Some experts recommend checking peak serum concentrations to ensure therapeutic levels, especially in difficult cases or if absorption is a concern. Expected levels around 2 hours post-dose would be 8-12 micrograms per milliliter for levofloxacin and 3-5 micrograms per milliliter for moxifloxacin. This level of monitoring helps ensure optimal drug exposure and efficacy, contributing to that elite professional level of care.
Okay, let's connect all this vital information to a real-world scenario. This is where the rubber meets the road. You're presented with a complex patient, a 60-year-old man who's had 2 months of fatigue, weight loss, fevers, night sweats, and a productive cough. Classic TB symptoms. He's been intermittently without housing, spending time in shelters, and reports drinking about 6 beers per day. So some social and medical risk factors there. His chest x-ray shows a right apical infiltrate, and his sputum smear reveals many acid-fast bacilli, high suspicion. To add another layer of complexity, an HIV test comes back positive. So what do we do? How do we approach this multifaceted case, applying everything we've learned to make sound clinical decisions?
This is indeed a classic complex presentation that demands a rapid and well-informed response, drawing on all the knowledge we've discussed today. Given the high suspicion for pulmonary tuberculosis, especially with acid-fast bacilli on sputum smear and his significant risk factors, homelessness, potential exposure in shelters, the immediate need is to start him on presumptive 4-drug therapy. We can't wait for full culture results. We have 2 recommended regimens for this initial intensive phase.
The ones we just discussed as first-line options, the traditional and the newer one.
Precisely. The first option is the traditional regimen: rifampin, isoniazid, pyrazinamide, and ethambutol, RIPE. The second is the newer 4-month regimen: rifampin, moxifloxacin, isoniazid, and pyrazinamide. Both are strong initial choices, but his specific comorbidities, especially the HIV, will guide our ultimate decision.
And what about his HIV co-infection? That seems like it would drastically complicate things, especially with those potent drug interactions we highlighted earlier, particularly with rifampin. This is where an elite professional needs to make nuanced decisions.
This is exactly where the nuanced drug interaction knowledge becomes critical, and it truly raises an important question about how we prioritize drug selection for patients with comorbidities. You nailed it. He should absolutely also be started on antiretroviral therapy, or RT, for his HIV as soon as possible, usually within a few weeks of starting TB therapy. The choice of his TB regimen needs to be carefully coordinated with his ART regimen, as interactions can compromise the effectiveness of either treatment. If we choose an efavirenz-based ART regimen for his HIV, the rifampin, moxifloxacin, isoniazid, pyrazinamide regimen for TB is largely compatible. Efavirenz is also an inducer, but it works reasonably well with rifampin, so that newer, shorter regimen could be a good option here.
But what if he needs to be on a different type of RT, especially one of the more potent regimens like protease inhibitor-based drugs or maybe an integrase inhibitor?
Right, that's where it gets trickier. If he needs to be on other types of ART, especially protease inhibitor-based regimens, then rifabutin should replace rifam in his TB treatment if we were considering the traditional regimen. This is because of the significant drug interactions between rifampin and protease inhibitors, which can lead to dangerously low levels of the protease inhibitors, compromising his HIV treatment. Rifampin is a less potent enzyme inducer, allowing for more stable ART levels. Similarly, if dolutegravir, which is an integrase inhibitor and very commonly used now, is chosen for his ART, it must be administered twice daily due to its interaction with rifampin, as rifampin speeds up its metabolism significantly. Alternatively, rifampin can again be used in place of rifampin, which would then allow for the standard once-daily dolutegravir dosing. These are not minor adjustments. They are critical for ensuring both life-threatening infections are treated effectively and safely, avoiding subtherapeutic levels of life-saving drugs. This is the art of balancing complex regimens.
And what about his personal history, specifically his reported alcohol use? Does that put him at higher risk for any of the drug toxicities we've covered, turning a standard side effect into a potentially life-threatening one?
Yes, unfortunately, his history of drinking about 6 beers per day significantly increases his risk of specific toxicities. We have to factor that in. The patient is at an increased risk of developing hepatotoxicity or liver damage from both isoniazid and pyrithinamide, given his history of alcohol use. This is a direct connection to the adverse effects we discussed earlier for both of those drugs, where alcohol can exacerbate liver damage. This underscores the need for vigilant monitoring of his liver function tests throughout his treatment, perhaps even more frequently than for a patient without this risk factor. It's a prime example of how patient-specific factors dictate personalized treatment and monitoring strategies. We can't just follow a standard protocol blindly.
Sometimes, despite our best efforts with first-line drugs, they aren't enough, or the patient simply can't tolerate them. That's when we turn to the second-line drugs, and this is truly where expertise comes into play, as these are often more challenging to manage, aren't they?
Indeed. Second-line drugs are typically considered in very specific, challenging situations. Their use signals a more complex case. Their primary indications are when there's documented resistance to one or more first-line agents, like MDR-TB, or if the patient fails to show a sufficient clinical or bacteriological response to conventional first-line therapy, indicating treatment failure. Additionally, they're used in cases of serious, treatment-limiting adverse drug reactions to the first-line drugs, where the side effects are simply too severe to continue. However, there are exceptions. For example, linezolid, which we'll discuss, might sometimes be chosen as an alternative to a first-line drug, even without documented resistance, simply due to its potentially more favorable toxicity profile for a particular patient with specific comorbidities or risks, although this is less common.
So it's not always just about resistance. Sometimes it's about finding the best tolerated, yet still effective combination for that individual.
Exactly. But it's crucial to stress that expert guidance is highly desirable, if not essential, when therapy with second-line drugs is required. This is because, for many of these drugs, factors like their precise optimal dosage, the patterns of resistance emergence, and their long-term toxicity profiles have not been as fully established or are simply more complex than for first-line agents. These are often more potent, frequently more toxic, and generally require more nuanced management by specialists experienced in treating drug-resistant TB.
Let's start with linezolid, a drug that's found a crucial niche in treating the toughest multi-drug-resistant TB cases. What makes it effective against these difficult strains?
Linezolid, an oxazolidinone antibiotic, is primarily known for its activity against gram-positive bacteria, like MRSA, but it also demonstrates good activity against tuberculosis in vitro, inhibiting strains at concentrations of 4 to 8 micrograms per milliliter. It's particularly useful because it achieves good intracellular concentrations, which, as we've repeatedly highlighted, is critical for targeting intracellular mycobacteria that hide within our immune cells. It has also shown promising activity in murine models of tuberculosis, supporting its clinical use for TB.
And how is it used in the clinic for TB, especially for those truly resistant strains? Is it part of specific regimens?
Linezolid has been utilized in combination with other second and third line drugs to treat patients with tuberculosis caused by multi-drug resistant strains for some time. Most recently, and very significantly, it is specifically recommended for use in combination with bedaquiline and predominid for multi-drug resistant pulmonary tuberculosis. This is often in a 6-month regimen, sometimes called the BPL regimen, bedaquiline, predominid, linezolid, typically at a dosage of 1,200 milligrams once daily initially, although dose reduction is common due to toxicity. This BPL regimen is a major advancement, offering a simplified, shorter, all-oral treatment for highly resistant forms of TB, representing a major step forward.
But I've heard it comes with some notable and potentially very serious adverse effects, particularly with prolonged use, which is often needed for TB. What are the key concerns?
It does, and this is a significant limitation of linezolid in TB treatment, often the dose-limiting factor. It's associated with significant adverse effects, especially with prolonged courses. These include bone marrow suppression, leading to anemia or thrombocytopenia, and more severely, irreversible peripheral and optic neuropathy. These neuropathies can be debilitating, causing numbness, tingling, pain, or vision loss. Because of these concerns, some experts actually favor using a lower 600 milligram daily dose, or even adjusting the dose based on therapeutic drug levels. As some data suggest that the 600 milligram dose is sufficient for efficacy in some cases and may limit the occurrence of these severe adverse effects, finding that balance is key. Furthermore, experts often recommend supplemental pyridoxine for patients treated with linezolid, similar to how it's used with isoniazid, although the underlying mechanism for the neuropathy is different. It's also generally avoided in patients on concomitant serotonergic agents, like SSRIs, due to concerns for serotonin syndrome, a potentially life-threatening condition.
Okay. Another important player in the second line, especially for patients with HIV, is rifabutin. How does it compare to its well-known cousin rifampin, and why is it so crucial for HIV co-infection?
Rifabutin is also derived from rifamycin and is chemically related to rifampin. It demonstrates significant activity against M. tuberculosis, Mycobacterium avium complex, MAC, and Mycobacterium fortuitum. Its overall activity against TB is quite similar to that of rifampin. However, it's important to note that cross-resistance with rifampin is virtually complete. This means that if an M. tuberculosis strain is resistant to rifampin, it is almost certainly resistant to rifabutin as well. While some rifampin-resistant strains might appear susceptible to rifabutin in vitro based on older testing methods, a clinical response is unlikely because the molecular basis of resistance, typically an RPB gene mutation, is the same for both drugs.
So if they're so similar in activity and resistance, why would a clinician choose rifabutin instead of rifampin, especially for HIV patients? This seems like a key decision point for professionals managing co-infection.
This is where rifabutin's pharmacokinetic profile, particularly its drug interaction potential, provides a crucial advantage. This is its main selling point. Like rifabutin is both a substrate and an inducer of cytochrome P450 enzymes. However, and this is key, it is a less potent inducer of these enzymes compared to rifampin, significantly less potent. Because of this, rifabutin is often used in place of rifampin for the treatment of tuberculosis in patients with HIV infection who are receiving antiretroviral therapy, RT. Many ART drugs, such as protease inhibitors, non-nucleoside reverse transcriptase inhibitors like efavirenz, and integrase strand transfer inhibitors like dolutegravir, are also metabolized by cytochrome P450 or UGT enzymes. Rifampin's potent induction would significantly lower the levels of these crucial ART-derived drugs, potentially compromising HIV treatment effectiveness. Rifabutin, being a milder inducer, allows for more manageable drug levels and better compatibility with ART, which is a major clinical advantage in co-infected patients. This allows us to treat both life-threatening infections simultaneously and effectively without sacrificing one for the other.
What about its dosage and adverse effects? Are they similar to rifampin?
The typical dosage of rifabutin is 300 milligrams per day. However, if the patient is concurrently receiving a protease inhibitor, the dosage should be reduced, typically by half, to 150 milligram a day, to account for the remaining drug interaction potential and prevent rifabutin toxicity. Conversely, if efavirenz, which is a strong CYP450 inducer itself, is used, the recommended dosage of rifabutin is actually increased to 600 milligrams per day to ensure sufficient therapeutic levels of rifabutin. Rifabutin may accumulate in severe renal impairment, so the dose should be reduced by half if creatinine clearance is less than 30 milliliters per minute. In terms of adverse effects, rifabutin is associated with similar rates of hepatotoxicity or rash compared to rifampin. It can also cause uveitis, eye inflammation, leukopenia, thrombocytopenia, and optic neuritis, so monitoring for these is important, just like with its cousin.
Now let's talk about bedaquiline, a truly groundbreaking drug. The first with a novel mechanism of action against M. tuberculosis in decades. What makes it so revolutionary?
Bedaquiline, a diroquinoline, received FDA approval in 2012, marking a significant milestone. As you said, it was the first drug with a truly novel mechanism of action against M. tuberculosis to be approved since rifampin back in 1971. That's over 40 years. Its unique action involves specifically inhibiting adenosine 5-uridotriphosphate, or ATP synthase, within mycobacteria. This is a crucial enzyme for energy production in the bacterial cell, essentially. It cuts off the bacterium's power supply. A totally different approach. What's particularly promising is its in vitro activity against both replicating and non-replicating bacilli, and it has demonstrated bactericidal and sterilizing activity in murine models of tuberculosis. This ability to target both active and dormant forms is a huge advantage for clearing persistent infection.
Does it have any cross-resistance with other existing TB drugs, or is it truly in a class by itself?
Well, mostly in a class by itself, but cross-resistance has been reported between bedaquiline and clofazimine. This is likely via the upregulation of a multi-substrate efflux pump called MMPL5, which can literally pump both drugs out of the bacterial cell, reducing their intracellular concentration and effectiveness. This is important to remember when designing combination regimens, especially for highly resistant strains where both might be considered.
And its pharmacokinetics seem quite unique, especially that remarkably long half-life. What are the clinical implications of that?
They are quite striking. The peak plasma concentration and overall plasma exposure to bedaquiline increase approximately twofold when it's administered with a high-fat meal. So it must always be taken with food to maximize absorption and ensure sufficient drug levels. That's a key counseling point. It's highly protein-bound, over 99%, and is chiefly metabolized through the cytochrome P450 system, with CYP3A4 being the major isoenzyme involved. It's primarily excreted via the feces. One of its most striking pharmacokinetic features is its exceptionally long mean terminal half-life, which is approximately 5.5 months. This incredibly long elimination phase likely reflects a slow release of bedaquiline and its major metabolite, M2, which is 4 to 6 times less antimycobacterially potent, from peripheral tissues where they are stored, acting almost like a drug reservoir. This means the drug sticks around for a very, very long time after stopping.
That incredibly long half-life must have significant implications for drug interactions, especially for other drugs that depend on CYP3A4 and also for toxicity monitoring, right?
It absolutely does, on both fronts.
Yeah.
Because CYP3A4 is the major isoenzyme involved in its metabolism, co-administration with potent inhibitors or inducers of this enzyme can cause clinically significant drug interactions, either by increasing its levels in potential toxicity or decreasing its levels in effectiveness. This requires careful consideration, especially with the complex multi-drug regimens used for drug-resistant TB. And yes, the long half-life means that if toxicity develops, it can take a very long time for the drug to clear the system, prolonging the adverse effect.
How is bedaquiline used clinically, and what are its notable and, in some cases, serious adverse effects?
Current recommendations indicate that bedaquiline should be included in treatment regimens for patients with pulmonary multi-drug-resistant TB. This recommendation is based on robust meta-analyses that have consistently shown an improved likelihood of treatment success and a lower risk of death in patients who received bedaquiline as part of their regimen, particularly for those with extensively drug-resistant TB, XDR-TB. It's a life-saving drug for many. The recommended dosage for bedaquiline is 400 milligrams once daily orally for the first 2 weeks, the loading phase, followed by 200 milligrams 3 times a week for an additional 22 weeks, maintenance phase. Always taken with food to maximize absorption and efficacy.
And the serious side effects. I recall a specific warning associated with it.
Yes. The most common adverse effects occurring in 25% or more of patients are nausea, arthralgia, joint pain, and headache. Relatively common, but usually manageable. However, bedaquiline has also been associated with both hepatotoxicity and, crucially, cardiac toxicity. The FDA has issued a black box warning specifically related to the risk of QTc prolongation, an electrical disturbance in the heart that can lead to dangerous irregular heart rhythms like torsades de pointe, and its associated mortality observed in some trials. Because of these serious cardiac risks, bedaquiline should generally be reserved for patients who do not have preferable treatment options, and must be used with extreme caution in patients with other pre-existing risk factors for cardiac conduction abnormalities, such as electrolyte imbalances or other QTc prolonging drugs. Regular ECG monitoring before and during treatment is absolutely essential. This drug is powerful, but its risks demand significant vigilance and expertise.
Following bedaquiline, predominant is another more recent addition to our fight against drug-resistant TB, with a fascinating dual mechanism of action. How does it work?
Predominant, approved by the FDA in 2019, is a nitroimidazoxazine compound belonging to the nitroimidazole class, and it's related to another TB drug called delamidid. Nitroimidazoles as a class require chemical reduction to become active. They're prodrugs. This selective activation within microorganisms is precisely what's responsible for their relative lack of toxicity to host cells. This prodrug nature, only activated by the bacteria, makes them quite clever drugs, minimizing off-target effects on human cells.
And its dual mechanism. That sounds quite unique for a TB drug. How does it manage to hit the bacteria in 2 different states like that?
It is indeed fascinating. M. tuberculosis appears to reduce predominant under both aerobic and anaerobic conditions, giving it activity against both actively replicating and latent, non-replicating forms of the bacteria. When the organism is actively replicating under aerobic conditions with oxygen, predominant primarily inhibits the production of the cell wall by blocking mycolic acid synthesis, similar in effect to isoniazid. However, what's truly fascinating here is its ability to target the organism when it's not actively replicating, specifically under anaerobic conditions without oxygen, which are common in dormant lesions or the center of caseous granulomas. In this state, the killing seems to be mediated by the release of nitric oxide, which can have multiple potential toxic effects on intracellular mycobacteria. This dual action against both active and latent states makes it a uniquely powerful agent, particularly against those persistent populations that cause relapse.
How is it handled by the body, and what are its potential drug interactions we need to know about?
Predominant is dosed orally at 200 milligrams daily, with an elimination half-life of approximately 16 hours. It's metabolized by multiple pathways, and notably, partly by CYP3A4. Therefore, co-administration with potent CYP3A4 inducers, like rifampin, though they usually wouldn't be used together, should be avoided due to the risk of subtherapeutic predominant levels, which could compromise treatment efficacy. Predominant is excreted in both the urine and the feces.
And how is it used clinically, especially for those toughest cases of drug-resistant TB? It sounds like it's part of a specific strategy.
Predominant was developed specifically to treat drug-resistant tuberculosis. It's not for standard TB. It is recommended by the CDC to treat extensively drug-resistant, XDR TB, pre-extensively drug-resistant, or treatment non-responsive multi-drug-resistant pulmonary tuberculosis. It's given in combination with linezolid and bedaquiline for 6 months, that BPL regimen we mentioned earlier. This combination represents a critical advance for patients with highly resistant forms of TB, offering a shorter all-oral regimen for previously very difficult or even untreatable forms of the disease.
What adverse events should we watch out for with predominant, especially when it's given in that powerful BPL combination? It's hard to tease apart sometimes.
Right, it can be tricky to attribute effects when drugs are combined. When predominant was administered as a single drug to healthy volunteers, it generally appeared to be well tolerated, with headache and gastrointestinal side effects being the most commonly reported. However, when administered in the BPL combination, the adverse event profile is more significant. It includes neuropathy, often from linezolid, headache, acne, anemia, GI symptoms, elevated liver enzymes, rash, and hyperanomalecemia, high amylase levels. While linezolid was initially thought to account for many of these effects, particularly the neuropathy and bone marrow suppression, predominant itself has also been associated with elevated liver enzymes, so routine monitoring of liver function is recommended during therapy. QT prolongation has also been observed with this regimen, though this is primarily a known effect of bedaquiline, so routine ECG monitoring is recommended to manage that risk. Other toxicities reported in less than 5% of study participants include pancreatitis, elevated creatine phosphokinase, electrolyte disturbances, and seizures. This highlights the need for close monitoring in patients on this powerful combination, acknowledging the potential additive or overlapping toxicities of the different drugs.
From the newer drugs, let's go back to a classic, streptomycin, an injectable drug that still holds a specific, albeit limited, place in our arsenal. What's its history and mechanism?
Streptomycin is an aminoglycoside antibiotic, and historically it was one of the very first effective anti-TB drugs discovered back in the 1940s, a true pioneer. Its mechanism of action, as with other aminoglycosides, involves binding to the bacterial ribosome, specifically the 30S subunit, and causing misreading of the messenger RNA, ultimately inhibiting protein synthesis. Resistance occurs due to point mutations in either the RPSL gene, encoding the S12 ribosomal protein, or the ROS gene, encoding 16S ribosomal RNA, which alter that binding site.
How effective is it against mycobacteria today? Is it still widely susceptible?
Most tubercle bacilli are inhibited by streptomycin at concentrations of 1 to 10 micrograms per milliliter in vitro. However, it's important to note that most non-tuberculous species of mycobacteria, with the notable exceptions of Mycobacterium avium complex and M. kinsasii, are actually intrinsically resistant to it. Furthermore, large populations of tubercle bacilli naturally contain some streptomycin-resistant mutants. Typically, around 1 in 10 to the power of 8 bacilli are expected to be resistant at concentrations of 10-100 micrograms per milliliter. This inherent presence of resistant mutants means it can never be used as a single agent for active TB.
Does it get into the cells, or is it primarily active elsewhere, like outside the cells?
Streptomycin penetrates into human cells rather poorly, meaning it is mainly active against extracellular tubercle bacilli. This is a limitation compared to drugs like isoniazid or rifampin that readily penetrate macrophages where TB hides. However, it can cross the blood-brain barrier and achieve therapeutic concentrations. but only when the meninges are inflamed, which is crucial for treating tuberculous meningitis.
How is it used clinically for TB today, given it's an injectable and has these limitations?
Streptomycin sulfate is typically used when an injectable drug is necessary as part of a multi-drug regimen, or in the treatment of infections that are resistant to other first-line drugs, making it essentially a second-line option now. The usual adult dosage is 1 gram per day or 15 milligrams per kilogram per day, administered intramuscularly or sometimes intravenously daily for several weeks initially. For children, it's 20-40 milligrams per kilogram per day, not exceeding 1 gram. Following this initial daily phase, it's often reduced to an intermittent regimen, such as 15 milligrams per kilogram 2 or 3 times weekly for several months to reduce toxicity. Serum concentrations typically reach around 40 micrograms per milliliter, 30-60 minutes after a 15 milligram per kilogram intramuscular injection. Crucially, like other drugs for active TB, streptomycin is always given in combination with other active drugs to prevent the emergence of resistance.
And the major adverse reactions for streptomycin, I recall hearing about some pretty significant ones related to its class, the aminoglycosides.
You're right. Aminoglycosides are notorious for certain toxicities. Streptomycin is both ototoxic, damaging to the ear, and nephrotoxic, damaging to the kidneys. The most common adverse effects and potentially permanent ones are vertigo, dizziness, balance problems, and hearing loss. This toxicity is directly dose-related, and the risk increases significantly in elderly patients and those with pre-existing renal impairment. As with all aminoglycosides, the dose must be carefully adjusted according to renal function based on creatinine clearance. To mitigate toxicity, it's often recommended to limit the duration of therapy to no more than 6 months whenever possible, particularly in these vulnerable populations, and switch to less toxic agents if feasible.
Briefly touching on other aminoglycosides, kanamycin and amikacin, what's their story and role in TB treatment? Are they similar?
Kanamycin was previously used for the treatment of tuberculosis strains that were resistant to streptomycin. It was another injectable option. However, it is no longer commercially available in the USA, largely having been replaced by less toxic and often more effective alternatives such as capreomycin and amikacin. Amikacin, however, has a significant and actually growing role in the treatment of tuberculosis, largely due to the increasing prevalence of multi-drug-resistant strains globally.
So amikacin is still a key player for resistant TB. Why is that? Is it more potent or less resistance?
It's still a key player, yes. The prevalence of amikacin-resistant strains is generally quite low worldwide, and importantly, most multi-drug-resistant strains of M. tuberculosis remain susceptible to amikacin. It inhibits M. tuberculosis at concentrations of 1 microgram per milliliter or less, and is also active against many atypical mycobacteria. There's an important point regarding cross-resistance within this class. There is no cross-resistance between streptomycin and amikacin generally, meaning an organism resistant to streptomycin may still be susceptible to amikacin, which is a major advantage. However, if a strain exhibits kanamycin resistance, it often indicates resistance to amikacin as well, due to shared resistance mechanisms, often modifying enzymes.
What are the pharmacokinetics and clinical use of amikacin, similar to streptomycin?
Peak serum concentrations of 30-45 micrograms per milliliter are typically achieved 30-60 minutes after a 15 milligram per kilogram intravenous infusion or intramuscular injection. Amikacin is indicated for the treatment of tuberculosis when it is suspected or known to be caused by streptomycin-resistant or multi-drug-resistant strains. It's a core second-line injectable. As with other drugs for resistant cases, it must be used in combination with at least 1, and preferably 2 or 3, other drugs to which the isolate is susceptible to prevent resistance emergence during therapy. The recommended dosage is typically 15 milligrams per kilogram, once daily initially, often followed by intermittent dosing 2 or 3 times per week after clinical improvement. Again, to minimize the risk of ototoxicity and nephrotoxicity associated with long-term aminoglycoside use.
Let's explore ethionamide, a drug chemically related to isoniazid, sharing some similarities in its action but with its own challenges, particularly regarding tolerance.
Ethionamide is indeed chemically related to isoniazid, sharing a similar chemical structure and, importantly, mechanism. It works through a similar pathway. It's also a prodrug activated by a mycobacterial enzyme, etha, and the activated form blocks the synthesis of mycolic acids, those essential components of the mycobacterial cell wall. This shared mechanism means there can be some low-level cross-resistance between isoniazid, especially due to ENIFEA mutations, and ethionamide, which is important for clinicians to recognize when choosing second-line drugs.
How is it administered and metabolized, and what about its activity levels against TB?
Ethionamide is poorly water-soluble, so it's only available for oral use. It is primarily metabolized by the liver. Most tubercle bacilli are inhibited in vitro by ethionamide at concentrations of 2.5 micrograms per milliliter or less. Some other species of mycobacteria are also inhibited, though at slightly higher concentrations of up to 10 micrograms per milliliter. With a dosage of 1 gram per day, serum concentrations in plasma and tissues typically range from 1 to 5 micrograms per milliliter. Importantly, cerebrospinal fluid concentrations are equal to those in serum, indicating good penetration into the central nervous system, which is a potential advantage for treating CNS tuberculosis.
What are the challenges with its dosing and, as you mentioned, its tolerance? This sounds like a big issue.
Yes, tolerance is a major hurdle with ethionamide. It's typically started at a lower dose, 250 milligrams once daily, and then gradually increased in 250 milligram increments up to the recommended dosage of 1 gram per day, or 15 milligrams per kilogram per day if tolerated. However, this 1 gram per day dosage, while theoretically desirable for efficacy, is unfortunately poorly tolerated by many patients. This is due to significant gastric irritation, nausea, vomiting, metallic taste, abdominal pain, and neurologic symptoms, headache, dizziness, psychiatric disturbances. This often limits the tolerable daily dose to between 500 and 750 milligrams, forcing clinicians to compromise on dose for patient adherence and comfort.
And its resistance patterns and other adverse effects besides the GI and neuro issues.
Resistance to ethionamide as a single agent develops rapidly both in vitro and in vivo, again underscoring the need for combination therapy. In terms of adverse effects, beyond the significant gastric irritation and neurologic symptoms we just mentioned, it is also hepatotoxic, meaning it can cause liver damage, so liver function monitoring is essential. The neurologic symptoms, much like those seen with isoniazid, may actually be alleviated by concurrent administration of pyridoxine, so that's a key management strategy to try and improve tolerance and safety.
Capreomycin, another injectable option, has a specific profile, especially concerning drug-resistant strains. What sets it apart from the aminoglycosides?
Capreomycin is a peptide protein synthesis inhibitor antibiotic derived from Streptomyces capreolus. It's chemically distinct from the aminoglycosides like streptomycin and amikacin. When administered as a daily intramuscular injection of 15 milligrams per kilogram, it results in peak serum levels of 35-45 micrograms per milliliter within about 2 hours. These concentrations are inhibitory for many mycobacteria in vitro, including multi-drug-resistant strains of M. tuberculosis, making it another valuable second-line injectable.
How does its resistance profile compare to other injectables like streptomycin or amikacin? Is there cross-resistance?
Capreomycin is a potential injectable agent specifically for the treatment of drug-resistant TB. Interestingly, M. tuberculosis strains that are resistant to streptomycin usually remain susceptible to capreomycin. This is a key point. It offers an alternative if streptomycin resistance is present. However, some data suggest there can be cross-resistance with strains that are resistant to amikacin and kanamycin. This is thought to be due to mutations affecting the ribosome, specifically the RS gene. So, susceptibility testing is crucial to guide its use. When resistance specifically to capreomycin occurs, it has also been associated with mutations in the LADA gene, which encodes a methyltransferase.
What are the main toxicities for capreomycin, similar to aminoglycosides?
Its primary toxicities are unfortunately similar to the aminoglycosides: nephrotoxicity, kidney damage, and ototoxicity, ear damage. The ototoxicity affects both hearing, tinnitus, deafness, and balance, vestibular disturbances, causing dizziness. These can be serious and potentially permanent. In addition to systemic toxicity, the injection itself can cause significant local pain at the injection site, and sterile abscesses may develop, which can make long-term injectable therapy difficult for patients to endure.
How is it typically dosed to manage these toxicities while maintaining efficacy? Same strategy as the others.
Yes, a similar strategy is employed. Capreomycin is typically dosed at 15 milligrams per kilogram per day initially. However, after an initial response has been achieved with this daily dosing schedule, the frequency is usually reduced to 2 or 3 times weekly. This intermittent dosing regimen is a strategy specifically employed to minimize the cumulative dose, and thus the risk of developing those significant nephrotoxic and ototoxic side effects, making long-term treatment more tolerable and safer while still providing sufficient drug exposure to be effective as part of a combination.
Cycloserine takes a different approach, targeting cell wall synthesis, but like many of these drugs, requires very careful management of its side effects, particularly neurological ones.
Cycloserine is a fascinating drug because it's a structural analog of the amino acid D-alanine. By mimicking D-alanine, it effectively inhibits enzymes involved in bacterial cell wall synthesis, specifically alanine racemase and D-alanine synthetase. D-alanine is a crucial component for building the peptidoglycan layer of the cell wall, so cycloserine acts as a molecular mimic that disrupts this essential process. Concentrations of 15-20 micrograms per milliliter inhibit many strains of M. tuberculosis.
What are its typical dosage and pharmacokinetics? How does it get around the body?
The usual dosage of cycloserine for tuberculosis is 0.5 to 1 gram per day, administered orally in 2 divided doses. It is widely distributed to various body tissues, importantly including the central nervous system, achieving good CSF levels, making it useful for CNS infections like meningitis. The drug is primarily cleared renally, so dosage adjustments are critical in patients with impaired kidney function. The dose should be reduced by half if creatinine clearance is less than 50 milliliters per minute. Alternatively, it can be reduced to 500 milligrams 3 times weekly for such patients.
What are the most serious side effects, and how are they managed, especially those neurological ones? This sounds like a major concern.
Yes, CNS effects are the main worry with cycloserine. The most serious toxic effects are peripheral neuropathy and significant central nervous system dysfunction. This can manifest as headache, irritability, depression, confusion, anxiety, and even overt psychosis or seizures. These can be quite severe. To ameliorate this neurologic toxicity, it's strongly recommended that pyridoxine, in dosages of 100 milligrams or more per day, higher than used for INH, be given concurrently with cycloserine. This can help prevent or reduce the severity. Adverse effects in general are quite common, occurring in 25% or more of patients, particularly during the first 2 weeks of therapy, and especially at higher doses that lead to peak concentrations greater than 35 micrograms per milliliter. To minimize these adverse effects and ensure patient safety, it's vital to monitor peak serum concentrations, which are reached 2 to 4 hours after dosing. The recommended therapeutic range for peak concentrations is between 20 and 35 micrograms per milliliter. This careful monitoring helps tailor the dose to the individual patient, reducing the risk of toxicity while maintaining efficacy.
Finally, for our second-line TB drugs, let's look at aminosalicylic acid, or PAS. This drug is seen less frequently today, but it's still part of the historical and ongoing story of TB treatment. What's its mechanism?
Aminosalicylic acid, commonly known as PAS, is a folate synthesis antagonist. It was actually one of the earliest anti-TB drugs developed around the same time as streptomycin. It is active almost exclusively against M. tuberculosis. Structurally, it is similar to para-aminobenzoic acid, or PABA, and its mechanism of action is thought to be similar to that of the sulfonamides, inhibiting the bacterial synthesis of folic acid by competing with PABA for the enzyme dihydroapterate synthase, which is essential for bacterial growth and replication.
How is it formulated and administered today? It sounds like it might be a bit tricky to take compared to a simple pill.
Yes, the formulation has changed over the years to improve tolerance. In the USA, PAS is commercially available as a 4-gram packet of delayed-release granules. To protect the integrity of this special coating and ensure proper absorption while minimizing stomach upset, the granules must be administered carefully. They should be sprinkled over acidic food like applesauce or yogurt, or swirled in fruit juice and then swallowed whole without chewing or crushing. This special formulation helps.
What about its activity and how it moves through the body?
Tubercle bacilli are usually inhibited in vitro by aminosalicylic acid at concentrations of 1 to 5 micrograms per milliliter. The delayed-release granule formulation results in improved absorption from the gastrointestinal tract compared to older tablets. It leads to peak serum levels of 20-60 micrograms per milliliter approximately 6 hours after a 4-gram oral dose. The typical dosage is quite large, 8-12 grams per day orally for adults or 300 milligrams per kilogram per day for children, administered in 2 or 3 divided doses. That's a lot of granules. PAS is widely distributed in tissues and body fluids, though notably it does not penetrate well into the cerebrospinal fluid, limiting its use for CNS infections. It is rapidly excreted in the urine, partly active PAS and partly as its acylated compound and other metabolic products. To avoid accumulation in patients with renal impairment, the maximum dose is limited to 4 grams twice daily when creatinine clearance is less than 30 milliliters per minute. One interesting point is that very high concentrations of aminosalicylic acid can be reached in the urine, which can sometimes result in crystalluria, where drug crystals form in the urine.
Why is it used infrequently in the USA today? It sounds like it has some challenges beyond its administration in large dose.
It's used infrequently in the USA primarily because other oral second-line drugs are generally much better tolerated. While the delayed-release granules have improved gastrointestinal symptoms compared to older formulations, GI discomfort, nausea, vomiting, diarrhea, abdominal pain is still common, though it may be diminished by giving the drug with meals and antacids. More seriously, peptic ulceration and hemorrhage can occur. Additionally, hypersensitivity reactions are a notable concern. These often manifest as fever, joint pains, skin rashes, hepatosplenomegaly, enlarged liver and spleen, hepatitis, adenopathy, swollen glands, and granulocytopenia, low white blood cells, and typically appear after 3 to 8 weeks of PAS therapy, often making it necessary to temporarily or permanently discontinue administration. Its broad range of side effects and the large pill burden, despite the improved formulation, still makes it a less preferred option compared to other second-line agents available today.
Okay, now let's pivot slightly from M. tuberculosis to a different but related group, the nontuberculous mycobacteria, or NTM. These organisms present their own distinct set of challenges and treatment approaches, often requiring a completely different set of drugs, right?
That's exactly right. Non-tuberculous mycobacteria, often referred to as NTM, were formerly known as atypical mycobacteria. These organisms have distinct laboratory characteristics, are commonly found in the environment in soil, water, even shower heads and tap water, and are generally not communicable from person to person, unlike M. tuberculosis. This is a key public health distinction. You don't typically catch NTM from another person.
So they're everywhere in the environment, but not generally spread human to human. That's crucial for infection control. And how do they respond to drugs compared to M. tuberculosis? Are they tougher?
Correct on the transmission. The key challenge with NTM species is that, as a rule, they are significantly less susceptible than M. tuberculosis to the standard anti-tuberculous drugs we've been discussing, particularly isoniazid and pyrazinamide, which are often completely ineffective against many NTM species. This inherent resistance makes their treatment much more complex. However, it's interesting to note that agents not typically active against M. tuberculosis, such as macrolides like azithromycin, clarithromycin, sulfonamides, and tetracyclines, can be quite effective for infections caused by NTM. Just like with M. tuberculosis, the emergence of resistance during therapy is still a problem with NTM species, so active infection should consistently be treated with combinations of drugs, often 3 or more, to prevent that.
Can you give us a few examples of specific NTM infections and their unique treatment approaches? It sounds complex.
Certainly. One important NTM is M. kansasi. It often causes a pulmonary disease that clinically resembles tuberculosis. M. kansasi is susceptible to rifampin and ethambutol, partially susceptible to isoniazid, but it is completely resistant to pyrazinamide. So the conventional treatment for M. kansasi infection is typically a 3-drug combination of isoniazid, rifampin, and ethambutol, often for 12 months or more.
What about Mycobacterium avium complex, or MAC? I know that's quite prevalent, especially in certain patient populations like those with advanced HIV or underlying lung disease.
MC, which includes both M. avium and M. intracellular, is a very significant NTM, and its treatment is indeed complex and long. It's particularly known for causing disseminated disease in the late stages of AIDS, especially when CD4 counts fall below 50 cells per microliter. MC is much less susceptible than M. tuberculosis to most standard anti-tuberculous drugs, necessitating combinations of agents, usually including a macrolide, to suppress the infection effectively. An effective regimen for disseminated MC disease typically involves azithromycin, 500 to 600 milligrams once daily, or clarithromycin, 500 milligrams twice daily, plus ethambutol, 15 milliglycerol of D. Some authorities also recommend the addition of a third agent, particularly rifampin, 300 milligrams once daily, especially for more severe disease or high bacterial load. Other agents like fluoroquinolones or amikacin might also be considered depending on severity and resistance.
And for prophylaxis against MM patients, preventing the infection from taking hold in the first place.
For preventing disseminated MSC in AIDS patients with CD4 cell counts below 50 per microliter, if the CD4 count is not expected to rise quickly with antiretroviral therapy. Azithromycin, often weekly, and clarithromycin daily are the prophylactic drugs of choice. While rifampin, at a single daily dose of 300 milligrams, have been shown to reduce the incidence of MSC bacteremia, it is generally considered less effective than the macrolides for prophylaxis and has more drug interactions.
What about pulmonary amyloid disease, which is distinct from disseminated disease and affects different patient groups?
MAC also causes pulmonary disease, which is more commonly seen in older individuals, often those without HIV, and has a higher prevalence observed in women, particularly those with underlying structural lung conditions like bronchiectasis or COPD. It's important to note that not all persons from whom MAC is isolated require treatment. Finding it in sputum doesn't automatically mean disease. Therapy is generally offered only when specific clinical and radiographic criteria are met, indicating active, progressive disease requiring intervention. When the organism is susceptible to macrolides, which most initial isolates are, a common treatment approach is a combination of azithromycin, often 3 times weekly, or clarithromycin daily, along with rifampin or rifabutin, and ethambutol. This 3-drug macrolide-based regimen, often given for 12 months after culture conversion, is the cornerstone for pulmonary MCC. Sometimes injectable amikacin is added initially for severe disease.
And are there many other types of NTM, each with their own treatment complexities? It sounds like a whole specialized field in itself.
Absolutely. The world of NTM is incredibly diverse, with dozens of species capable of causing human disease, each with unique susceptibilities and clinical presentations. Beyond M. kansasi and M. assi, we encounter species like M. marinum, which causes fish tank granuloma, a skin infection often linked to exposure to contaminated water. There's M. scrofulaceum, historically linked to cervical lymphadenitis, scrofula, in children, and the rapidly growing mycobacteria like M. abscessus, M. colonae, and M. fortuitum, which can cause skin, soft tissue, bone, or lung infections, often related to surgical procedures, trauma, or medical devices. These are notoriously difficult to treat. Then there's M. ulcerans, responsible for severe skin ulcers known as Buruli ulcer, primarily in tropical regions. Each of these has a unique susceptibility profile, and their treatment often involves a wide variety of antibiotics, sometimes for very long durations, including aminoglycosides like amikacin, tetracyclines like doxycycline or minocycline, carbapenems like imipenem, newer macrolides, linezolid, trimethoprim sulfamethoxazole, fluoroquinolones like moxifloxacin, clofazimine, sometimes even surgery. It truly highlights the highly tailored, often challenging, and specialized approach necessary for NTM infections, requiring expert consultation.
Finally, let's turn to another significant mycobacterial disease, leprosy, also known as Hansen's disease. It presents a unique challenge, primarily because its causative agent is so difficult to study in a laboratory setting.
Leprosy is indeed caused by a distinct mycobacterial foe, Mycobacterium leprae, and you've highlighted its most challenging aspect for research. M. leprae has never been successfully grown in vitro, meaning in a standard laboratory culture medium. Never. This makes studying it and evaluating new drugs incredibly difficult and slow. We can't just test drugs in a test tube easily. Because of this, we largely rely on animal models, such as its growth when injected into mouse footpads or armadillos, to conduct laboratory evaluations of potential drugs and observe their effects in a living system. For our discussion today, we'll focus only on those drugs that have the widest and most established clinical use in treating leprosy, which are well documented despite the research challenges.
Dapsone is a cornerstone in leprosy treatment, with a long history and mechanism linked to the sulfonamides. What makes it effective?
Dapsone, or diaminodiphenylsulfone, is a drug closely related to the sulfonamides and has been used effectively in the long-term treatment of leprosy for decades, really transforming the prognosis for millions. Like the sulfonamides, its mechanism of action involves inhibiting folate synthesis, which is essential for bacterial growth and replication. It acts as a competitive inhibitor of dihydroxyapatite synthase, an enzyme critical in the bacterial folate pathway.
Does resistance develop to dapsone, and why is combination therapy important here too, just like in TB?
Yes, resistance to dapsone can emerge, particularly in large populations of M. leprae, such as those found in lepromatous leprosy, the form with high bacterial load, especially if low or inadequate doses are given, or if it's used as a single agent for too long. To combat this and ensure effective cure while preventing relapse, multi-drug therapy, MDT, as recommended by the WHO, is absolutely essential. For the initial therapy of multibacillary leprosy, the higher load form, the standard WHO MDT combination is dapsone, rifampin, and clofazimine, typically for 12 months. For paucibacillary leprosy, the lower load form, the combination is dapsone plus rifampin, typically for 6 months. Beyond leprosy, dapsone also finds use, often in combination with other drugs, for preventing and treating pneumocystis jirovecii pneumonia, PJP, in immunocompromised patients, including those with AIDS.
How does dapsone move through the body, and what are its general side effects?
Sulfones like dapsone are generally well absorbed from the gut and widely distributed throughout body fluids and tissues. Dapsone has a relatively long half-life of 1 to 2 days, and it tends to be retained in various tissues, including skin, muscle, liver, and kidney. Interestingly, skin that is heavily infected with M. leprae may contain several times more drug than normal skin, which is advantageous for its local action against the bacteria right where they live. Sulfones are excreted into the bile and then reabsorbed in the intestine, undergoing enterohepatic recirculation. Excretion into the urine is variable, with most of the excreted drug being in its acetylated form. In patients with renal failure, the dose may need to be adjusted. The usual adult dosage for leprosy in MDT is 100 milligrams daily, with proportionately less for children depending on their weight.
What are the common adverse reactions, and is there anything specific to watch out for with dapsone besides general side effects?
Dapsone is usually relatively well tolerated, especially compared to some TB drugs. Many patients may experience some degree of hemolysis, breakdown of red blood cells, particularly if they have glucose 6-phosphate dehydrogenase G6PD deficiency, so testing for this condition is important before starting, especially in populations where it's common. Mesmeglobinemia, a change in hemoglobin that reduces oxygen carrying capacity, is also common, but typically not clinically significant unless severe. Other possible adverse effects include gastrointestinal intolerance, fever, pruritus itching, and various rashes. A rare but serious reaction is dapsone hypersensitivity syndrome, a unique and significant adverse event that can occur during dapsone therapy or anti-leprosy therapy are the leprosy reactions. The most common type in lepromatous leprosy is erythema nodosum leprosum, ENL. This is an immune-mediated inflammatory reaction that often develops during the course of treatment as the bacteria die off. It causes tender red nodules on the skin and can be accompanied by fever, nerve pain, joint pain, and eye inflammation.
It can sometimes be challenging to distinguish these reactions from drug side effects or manifestations of the underlying illness itself. ENL reactions may need to be suppressed with drugs like corticosteroids or thalidomide.
Rifampin, which we extensively covered for TB, also plays a crucial role here in leprosy. How effective is it in this context? Is it just as important?
Absolutely. Rifampin at a dosage of 600 milligrams is highly effective in treating leprosy, serving as the most powerfully bactericidal component of multi-drug therapy. It kills bacilli very quickly. And similar to its use in tuberculosis, it is always given in combination with at least one other drug, dapsone plus clofazimine, to prevent the rapid emergence of resistance in M. leprae. Because it's so potent, even an intermittent supervised dose of 600 milligrams per month, as used in WHO MDT regimens, is highly beneficial and sufficient when used as part of combination therapy for leprosy. This makes supervised administration feasible globally.
Our final drug for leprosy, clofazimine, is a phenazine dye with a unique absorption and storage profile. What's its role in MDT?
Clofazimine is a phenazine dye primarily used in the WHO MDT treatment regimen for multibacillary leprosy, the form defined by positive skin smears indicating a high bacterial load. It has both antibacterial and anti-inflammatory properties. Its exact mechanism of action against M. leprae has not been clearly established, which is quite intriguing, but it is thought to involve binding to mycobacterial DNA and disrupting membrane function. Its anti-inflammatory effects are also helpful in preventing or managing leprosy reactions like ENL.
What about its pharmacokinetics? You mentioned its unique storage in the body.
Its absorption from the gut is quite variable, and a major portion of the drug is excreted unchanged in the feces. However, what makes clofazimine truly unique is that it is stored widely in fatty tissues and cells of the reticuloendothelial system, like macrophages in the liver, spleen, lymph nodes, and especially the skin. Its crystals can actually be seen inside phagocytic reticuloendothelial cells, highlighting this deep tissue deposition. Because it is slowly released from these tissue deposits, its serum half-life can be remarkably long, potentially up to 2 months or even more, allowing for sustained drug levels even with daily or intermittent dosing.
And its typical dosage and most prominent adverse effects. Anything patients need to know.
A common dosage of clofazimine in WHO MDT is 50 milligrams daily, plus a larger supervised dose of 300 milligrams once monthly. The most prominent adverse effect, and one that patients should be counseled about extensively because it affects adherence, is a harmless but very noticeable discoloration of the skin and conjunctivae. The skin turns reddish-brown to dark purple over time, especially in sun-exposed areas. This can be cosmetically significant and stigmatizing in some cultures. The discoloration fades very slowly after stopping the drug, sometimes taking months or years. Gastrointestinal side effects are also common, including abdominal pain, nausea, and diarrhea, sometimes related to crystal deposition in the gut wall.
Is clofazimine widely available globally, or are there access challenges like with some other older drugs?
Historically, access has sometimes been an issue, but clofazimine is a core component of the WHO's global strategy to eliminate leprosy, and they provide MDT blister packs containing clofazimine, rifampin, and dapsone free of charge to endemic countries. While it might not be commercially available for purchase in all countries, like the USA, where it requires special access via the National Hansen's Disease Program, or IND, its availability through these established public health programs ensures that patients needing it for leprosy generally have access. This highlights its continued importance for this specific disease, despite limited use elsewhere.
So what does this all mean for us? This deep dive into antimicrobacterial drugs has really shown us a world of complex, targeted pharmacology, demanding a level of mastery that goes way beyond simply knowing drug names and standard doses.
This deep dive truly underscores the unique and formidable challenges posed by mycobacteria. It's quite humbling, actually. We've seen how their inherent properties, their slow growth, their ability to remain dormant, their tough, lipid-rich cell walls, and their intracellular nature make them incredibly stubborn pathogens, fundamentally resistant to many conventional antibiotics. Their notorious ability to develop drug resistance further complicates treatment, forcing us to think strategically from the very first dose to prevent failure down the road.
And this leads directly to the core principle of combination therapy, right? Why is that multi-drug approach so non-negotiable, especially for TB?
Absolutely. The non-negotiable principle for effective treatment and preventing resistance in active infections, especially tuberculosis, is the use of multi-drug regimens. Combining agents like isoniazid, rifampin, pyrazinamide, and ethambutol in the first line. This is a mathematical necessity, as we discussed, to overcome the probability of naturally occurring resistant mutants within a large bacterial population before treatment even starts. Understanding this probabilistic rationale is key to mastering TB treatment and explaining its importance to patients.
We also talked a lot about pharmacokinetics and the body's interaction with these drugs. It's not just about what the drug does to the bug, but what our bodies do to the drug, right?
Right. Yes. Understanding the pharmacokinetic nuances is crucial for effectively using these drugs and minimizing harm. We saw how isoniazid's absorption can be affected by food and how its metabolism is genetically determined by N-acetyltransferase, influencing individual drug levels and toxicity risk. Rifampin's potent induction of cytochrome P450 enzymes causes significant drug interactions that demand careful management and precise dose adjustments or drug choices for co-administered medications, especially RT, and the renal clearance of drugs like ethambutol, pyrazinamide, streptomycin, amikacin, capreomycin, and cycloserine means dosage adjustments are vital in patients with kidney impairment to prevent accumulation and toxicity. This deep knowledge of drug absorption, distribution, metabolism, and excretion is what allows clinicians to truly master these treatments and ensure patient safety and efficacy at that elite professional level.
And the adverse effects, they're quite specific and require vigilant monitoring, not just general checkups. You really need to know what to look for.
Precisely. The need for careful monitoring for specific toxicities is paramount with these agents. We've highlighted isoniazid's potential for hepatotoxicity and peripheral neuropathy, often preventable or mitigated with pyridoxine. Ethambutol's retrobulbar neuritis requires regular visual acuity and color discrimination testing. You can't skip that. The aminol glycosides and capreomycin carry risks of hearing loss, balance problems, and kidney damage. Bedaquiline's QTC prolongation demands specific cardiac monitoring via ECGs. Lanezolid needs monitoring for neuropathy and blood counts. And even things like the GI side effects of ethionamide or the skin discoloration of clofazimine, while not life-threatening, significantly impact patient quality of life and adherence, which is critical for cure. Being an elite professional in this field means not just knowing what drugs to give, but how to safely anticipate, monitor, manage, and mitigate their impact on the patient throughout their long treatment journey.
And it's not a static field, is it? We're always evolving, finding new strategies, new drugs, shorter regimens.
That's right. The advancements in treatment, such as the newer 4-month regimen for drug-susceptible TB, using rifampin and moxifloxacin, and the specialized approaches for drug-resistant TB, including combinations with bedaquiline, predomandid, and linezolid in the BPL regimen, demonstrate our constant effort to refine these strategies, make them shorter, more effective, and less toxic. And of course, we discussed how nontuberculous mycobacteria and leprosy require distinct, though sometimes overlapping, therapeutic strategies, reflecting the incredible diversity within the mycobacterial family itself. So what's truly fascinating here, I think, is the sheer ingenuity required to tackle these infections, constantly adapting our strategies to the unique and often cunning biology of the pathogens we face.
What stands out most to you from this deep dive? We've covered a tremendous amount of ground today, from the incredibly stubborn nature of mycobacteria to the intricate mechanisms and toxicities of the drugs we use to combat them, and the crucial insights needed to truly master this challenging field.
I think if we connect this to the bigger picture, the constant evolution of these pathogens, especially the development of drug resistance, means our understanding and our development of new drugs and strategies must also continue to evolve relentlessly. It's a never-ending arms race, really, driving continuous research and clinical innovation just to stay ahead or even just keep pace with these resilient microorganisms. It underscored the dynamic nature of infectious diseases and medicine itself.
Indeed. A constant challenge. Perhaps now, when you hear about multi-drug resistant TB or XDR TB in health news, you'll appreciate it with a whole new level of understanding, recognizing the immense challenge it represents for patients and healthcare systems worldwide. Or maybe you'll ponder how these tiny, slow-growing organisms have shaped global health policies, driven the development of directly observed therapy programs, and spurred research for decades. There's always more to learn. Keep digging into the incredible world of science.